So welcome everybody to our session, Police-Based Models and Mental Health Crisis Response Alternatives. My name is Amy Watson. I'm a professor at Helen Bader School of Social Welfare at the University of Wisconsin-Milwaukee. I am also currently the president of the CIT International Board of Directors. I am joined today in the session with three of my awesome colleagues that I'll have introduce themselves. Jen?
Hello, my name is Jennifer Wood. I'm a professor of criminal justice at Temple University.
Michael?
Hi there, I'm Michael Compton. I'm a professor of psychiatry at Columbia University.
Leah?
Hi, Leah Pope. I am an anthropologist and an assistant professor at Columbia University.
All right. So before we get started, I just want to, I'm sorry, I have my hand raised and I didn't mean to. Before I get started, I just want to make some acknowledgements. What we're presenting today, a lot of the work that went into it was funded by the Bureau of Justice Assistance via a grant to the Vera Institute's Serving Safely project. And what we did is we worked with the Research and Evaluation Committee of Serving Safely, and we identified existing models of partnership between police and mental health, and also disability service providers. And we prepared a literature review on those models, and then went through and developed a research agenda for the U.S. Bureau of Justice Assistance and other federal agencies. And that report is available on the Vera Institute website. At some point during the session, I'll try to get that link into the chat as well. So just to provide an overview of what we'll cover in this session, first we'll talk a little bit about the role of police and how it's become a role of mental health interventionalists. And then we're going to cover existing models and strategies. That includes police-based response models as well as non-police mental health crisis response alternatives. Then we'll talk a little bit about what we know about service users' experiences and preferences. We'll cover implications for race equity in the models that exist and what may emerge in the future. And we hope to have some time for discussion and questions. So I'll hand it over to my colleague, Jen Wood.
Thanks, Amy. Law enforcement officers have long played a role in responding to mental health crises. This was documented as far back as at least the 1960s. Over the past 50 years, police have increasingly become de facto mental health crisis responders. And because of that, the criminal justice system has evolved into a de facto mental health system. This is due to a decades-long process involving the transition of individuals with serious mental illnesses from large state psychiatric institutions to inadequate treatment in underfunded community programs and then into criminal justice institutions. In the United States, primarily local jails, but also state prisons. This half-century long process, I should say, of shifting this responsibility from the health and social services sector to the law enforcement sector has undermined this country's commitment to community safety and well-being. If we look at the data that we have, we know that 6 to 10% of all police contacts with the public involve persons with serious mental illnesses. This is obviously a significant underestimate due to the limitations of our data collection systems and our police administrative data. We know that 29% of persons with serious mental illnesses in the United States have had police involved in a pathway to care. And this number is even higher in urban public health, mental health settings. At least 1 in 4 individuals in the United States that have been fatally shot by police had a serious mental illness. So overall, we know that over 1 million arrests of persons have involved, million arrests of persons with mental illnesses per year in the United States. So if we look at the data on experiences of people with serious mental illnesses, we know that individuals in crisis experience heightened vulnerability and stress during encounters, and that this can escalate during crises. We know that involvement in the criminal legal system, and as that involvement deepens, it can amplify experiences of stigma. We know that system involvement exacerbates unmet behavioral health needs. And we also know that once they are in the system, they stay longer. For example, once individuals are detained, only about half of those with serious mental illnesses receive treatment. And we also know that incarceration exacerbates health disparities. If we look at the literature on experiences of police, particularly the qualitative literature, we hear from officers that mental health responses ideally should not be their core function. They have received little training in this area historically, so we have sent them out into the world with limited training, little tools to serve as mental health interventionists, and that they yearn for more tools beyond arrest and hospital transport. Overall, police work in a service system vacuum. The mental health system is deficient. The follow-up system is deficient. And officers routinely experience encounters where they were trying to help families who are in need, families who are caring for loved ones with mental illnesses. So this isn't just encounters involving individuals with mental illnesses, but officers also see that wider family units need support as well. So when we look at the experiences of police, and if we look at what we're learning in terms of the voices of people who experience encounters with the police, people who are affected by serious mental illnesses, it's critically important that we understand those experiences in context, that they are having these experiences in the context of a deficient, underfunded mental health system. And also we are, listening to these voices in the wake of very significant and important calls to reimagine public safety, to reimagine which institutions should be delivering public safety, and to really advance new institutional arrangements that really address the institutional racism that we are seeing that runs across the law enforcement and public health sectors. Thank you.
Great. So we're going to move on now to talk about existing models and strategies. And I highlight existing because I think, as we've been talking about in many sessions this week, there are opportunities for new models as well. But our goal here is to really review the evidence for existing models. As we think about existing models, I put up this graphic of something that I think is helpful that we created when I was at the Vera Institute of Justice last year. And this is really just one way to visualize the role of police in existing responses, almost like a sliding scale of more to less involvement. So you can see here on the left that there are police-based responses where police are really primary responders. And then obviously, as we've evolved over time, there have been more and more models that have come into existing, some of which include police as partners, and then going even further to the right, responses that are really primarily community-based. If we move on to think about kind of a different way to characterize these, we could think of kind of two categories. You can move to the next slide, Amy.
Sorry.
That's okay. Kind of a bucket of police-based responses and a bucket of non-police, primarily mental health crisis response models. We know these categorizations are not perfect, but I think they're the best we have right now in terms of how to think about them broadly. So in the police-based crisis response model category, we have models such as crisis intervention teams, co-responder models, case management or high utilizer team models, and officer notification and flagging systems. And we'll be going through the evidence for each of these and talking a little bit about how there are multiple variations within these categories. Then on the non-police side, we think about more models such as mobile crisis teams, which have been around for a very long time, EMS or ambulance-based response teams, which might paramedic with as the primary response, and then increasingly 911 diversion models where different response units can be sent out at the point where 911 is contacted. Another way to think as we're talking about the evidence for these models is what we see as kind of 4 categories of how to think about the models. And I think thinking through these 4 categories also enables us to think about what other types of models we might want to create in the future along these different categories. So one of the first categories is, how is the unit dispatched, or how are they accessed? How do people in the community get this service? And that may be through 911, it may be through calling a crisis line, it may be through another means. And as I've heard in many conversations this week, one of the primary questions for any community is, what does that kind of dispatch system look like, so that you can figure out what resources can be accessed when. The second big category is who's actually responding. Who are the people in the unit that are going? Is it police? Is it EMS and fire? Is it clinicians, crisis workers, medics, peers? There's a whole host of options and different kind of innovations going across the country with different pairings that I think are really interesting to see evolving. I think the next category is really the transport. I think there's been less attention to this, but what's actually physically transporting the person in crisis, if a transport's needed, is a really interesting question. And we're seeing innovation in that regard too, since police cars may not be the most supportive environment in a time of crisis, or ambulances for that matter. And then the larger question of, where is the service housed? So is this unit being run out of a police agency, out of EMS, or out of a mental health agency? And I think they're really important implications for how the model is set up as a result of where it's run and where the funding comes from. So I'll turn it over now. We're going to kind of dive into the literature.
Am I up here, Amy? Great. So I'm going to start by talking about the CIT model. And this is the model that has the most evidence, and that's because it's had the most research. There's a really good document out available, it's shown here, available from CIT International, that really describes in great detail what CIT is and how it's implemented at the local level. But at its heart, CIT is a partnership. The team in CIT is really about community partners that come together around the table, that include not only the police agency where the CIT program is housed, but also local mental health services and, importantly, local advocates, including family members and persons with lived experience. And so the team is not the team that's responding to a mental health call, but rather the team that is sort of overseeing and organizing the jurisdiction's CIT program. One important part of CIT is having a single point of entry so that officers have somewhere to drop off individuals who need psychiatric evaluation or who are in psychological crisis. And probably what's best known about CIT is the 40-hour training program that select officers go through. So again, the team in CIT is really about the partnership at the local level that plans the CIT program, that oversees it, and that monitors it as it goes along. This is sort of a cutout of a typical CIT training week. Again, this is a 40-hour training week. It usually includes about 20 officers. Ideally, they're self-selected into the CIT program and then become specialized CIT response officers. The typical 40-hour CIT training week covers a number of topics related to mental health, and probably about a third of the training week is sort of didactic But importantly, another roughly third is de-escalation skills training. And a big part of this is role play scenarios where officers are able to really practice their active listening skills and their verbal de-escalation skills. And then another portion of the CIT training week is actually site visits to local mental health services so that officers have a chance to interact with individuals with mental illnesses when they're, you know, in a mode of stability, and also their family members, to learn about what it's like to have that lived experience and to visit the services. So there's been quite a bit of research on CIT. This is just a picture of a drop-off center for CIT officers, which again is an important part of the model. A lot of research now demonstrates that CIT clearly improves officers' knowledge, attitudes, their confidence. It reduces their stigma. It improves their decision-making. There's a fair amount of research that shows that CIT increases linkages to services. It likely reduces the use of force. And there is evidence that it also improves diversion from arrest, which is really at the heart of CIT as a form of pre-arrest jail diversion. And we have a little bit of evidence that actually shows that the effects of CIT are strongest when CIT officers self-select or volunteer to become specialist CIT officers. And then finally, there's some evidence that CIT can be adapted to very, very different types of settings outside of the U.S. and other high-income countries, as exemplified by a demonstration in Liberia in West Africa. This is just a picture of one of our articles that really demonstrated in a very solid way that CIT training improves officers' knowledge, skills, attitudes, reduces their stigma. And this finding was among 586 officers, and the CIT officers were at a median of 22 months after their training. So the evidence isn't just an immediate improvement right after the CIT training week, but rather for some time longitudinally. And then we also have, from this same study, we have some evidence that that CIT really is able to reduce arrest, increase referral to mental health services, and potentially reduce the use of force. And then also from this same study, we were able to demonstrate that CIT officers who self-select or volunteer into CIT training actually have better outcomes, again, in terms of knowledge, attitudes, confidence, and reduced stigma. So we really think that this self-selection element of CIT, which is part of the core elements, is in fact important. We also know that the impact of CIT might vary by location, and this is from Dr. Watson's study in Chicago that really shows that CIT's effects might be greater in areas where there are greater mental health services. And so there are probably important interactions between the training itself and the local context, whether that's within the police agency or within the patrol district.
So now I'm going to talk a little bit about the co-responder model, which is what we call it in the US, but it's also called street triage or the PACER model. When we really looked at the literature, it was really clear that this is a predominant model in Canada and the United Kingdom, and there's growing popularity in Australia, and really in the last few years, it's gaining popularity in the United States. And what these models typically look like are a pairing of a clinician and an officer to provide response to a behavioral health crisis in the community. There's significant variation, however, in kind of how these models are implemented. And so it could be, in many places, you have a clinician that rides with a police officer in a police car. But in other communities, they may arrive separately, but then respond to the situation together. And still other communities, sometimes the clinician provides telephone support and it's only the officer that's providing response on the scene. These programs also vary in terms of kind of when they respond. In some communities, the co-response team is dispatched directly from 911 to hot calls. So they're the first response on scene. In other communities, they respond as a secondary response. So a first responding officer goes out, recognizes that the call is appropriate for the co-response team, and then requests that they come to the scene. And still other places, these co-responder teams serve more of a follow-up role to police calls. The actual hours of operation may vary as well. Some communities, many communities aren't able to have the teams running 24/7. So they may be running 5 or 7 days a week and then limited shifts. Typically they try to target the days and times when the most calls are occurring. We're also starting to see co-response teams that include emergency medical technicians, certified peer specialists. So sort of the makeup of these teams, we're seeing some variation in as well. But overall, the goals of these teams really are, one, to reduce emergency room transports and hospitalization, to reduce arrests and increase safety. So getting a clinician on scene to hope to increase the safety, but also to have a better outcome for the person. Also, the goals are for the clinician to help then increase linkage to community care for that person in crisis in hopes of really getting people connected to the care they need to stay stable in the community and hopefully reduce repeat calls for service. So when we looked at the literature, the first mention of co-responder teams we found goes back to 1995, and it was an article about the Los Angeles system-wide mental health assessment response team. And Richard Lamb published a paper on it and basically concluded that the teams were able to respond to individuals that were acutely ill, some of whom were violent, and they felt that they were able to reduce entry into the criminal justice system. So there wasn't a lot in terms of newer publications between 1995 till 2010, but since 2010, we've really seen an increase in articles and research on co-responder teams. Much of it is descriptive. Really, and in terms of, I think, in 2010, we started to see more articles coming out of the UK, coming out of Canada and Australia. In the past few years, there's kind of been an explosion in work looking at these teams in the US as well. So in terms of what the evidence tells us so far, there's been 2 systematic reviews of co-responder teams and a number of quasi-experimental and descriptive research studies. So again, similar to CIT, we don't have a randomized controlled trial. However, we do have, a growing body of research that suggests that co-responder teams are addressing some of the desired outcomes. We have some good evidence that these teams are acceptable to the different stakeholders that are involved, that implementing these teams can improve collaboration between police and mental health providers. There's some evidence to suggest that in some communities that deploying these teams can reduce officer time on scene. We also have a few studies that have found that co-responder teams can reduce emergency department transports, but increase the admission rate for those that are transported. So basically having a clinician on scene to respond allows for that assessment to be done to determine if that transport is necessary. So it can reduce the unnecessary ED transports, which of course we know are very expensive and disruptive and not always entirely helpful for folks. There's also some evidence to suggest that co-responder teams can reduce repeat calls for services and get people better connected to care in the follow-up period. So having that clinician on scene allows for getting some things set up for that person so that they can connect to care in the community. So in terms of overall looking at the evidence, some of the themes that have come out of it as well. One has been many of the stakeholders have expressed concern about the lack of community mental health services as an issue for co-responder programs. And of course, this is an issue for CIT programs and other models as well, that, you know, we can develop these models, but we also need to really work to have a robust community mental health system for these crisis responder teams to connect people to. There's also a few studies that did qualitative interviews with clinicians and with service users and that have expressed some concern about including police officers in events that might be better handled just with a mental health only response. Additionally, you know, what we're seeing in terms of what the benefits are of co-responder teams, they do appear to be similar to those of mobile crisis teams that I believe Leah is going to cover in a few minutes. So I believe Jen will be talking about the linkage and case. I'm sorry, I'm passing it over to Jen. Is that correct?
Thank you.
Sorry.
Yeah. Just quickly, there's some really promising examples of case management linkage or high utilizer focused interventions that have a follow-up piece. And you may recall that the follow-up piece is sorely lacking in this country. So overall, these models are designed to address individuals who have had frequent contact with police or other emergency responders and are considered high risk. And I should note that how high risk is conceptualized and measured varies across sites, but that is the emphasis. And then there's a follow-up care piece in place once they've identified those individuals to work with. A couple of examples are the Portland Police Behavioral Health Response Team. So in Portland, the response team involved a clinician that's paired with a police officer, and they proactively work with individuals who have multiple contacts with police to attempt to connect them with appropriate services in advance of a mental health crisis. So to prevent that next mental health crisis from potentially occurring. A similar initiative is the LAPD Case Assessment and Management program, again, where we have an emphasis on a detective, an officer, in this case, detective clinician team triaging cases based on level of risk and advancing engagement, follow-up and monitoring with those individuals. And there's an emphasis as well on removing firearms. The Houston Consumer Stabilization Initiative is a collaborative effort between the Houston Police Department and the Harris Center for Mental Health and Intellectual Disabilities. It's a program designed to identify, engage, and provide services to individuals who have been diagnosed with a serious and persistent mental illness and who have had frequent encounters. So the CCSI staff work with these individuals to attempt to engage them in mental health services and provide assistance in acquiring needed social services. The goal here is to interrupt the cycle of repeat encounters with law enforcement and repeat psychiatric hospitalizations. There was a study that was focused on evaluating what happened when wraparounds were put in place for 30 individuals with serious mental illness who were the highest utilizers of police services. This study reported that police contact was reduced by 70% in the first 6 months. So I'll hand it back over to Michael.
Thank you. So just briefly, one sort of model is where responding officers get some sort of notification or flag that the subject might have a mental illness. And so, one example of this is Smart 911, which allows one to create a safety profile. Another example came from the Janesville Police Department, which gives officers like a visual indicator in the county law enforcement records to alert the officer of a known mental illness. And then it also gives tips about triggers and potential calming approaches, and allows individuals with mental illnesses to include a crisis strategy. There are also forms of communication cards, sort of similar to a medic alert bracelet. And these notification approaches can be useful, but we do have to keep in mind issues around voluntariness of these models. We're studying one in Georgia right now, created in Georgia, that basically piggybacks onto the background check or the inquiry system, such that when an officer runs an inquiry on someone, if the individual with mental illness has signed up for the system, the officer will get a notice that the person is in mental health treatment and to call a number for support. And this goes to the mental health clinic such that the officer can have a quick conversation with the social worker. And so it's basically a form of advance directive that very temporarily brings down HIPAA so that the officer can actually call a mental health clinic. We're studying this approach in Georgia right now after we were able to find that both patients with serious mental illnesses and officers find it to be an acceptable and useful approach. And then we also found preliminary evidence of a possible reduction in arrests among 200 patients. And so now we're studying this in a much larger way in a randomized controlled trial, including 1,600 outpatients. So those are some examples of this sort of notification approach for officers.
Great.
And
so
turn it back to Leah.
Yeah, we're gonna move right along, going through these models quickly, we realize. So we're gonna move over to non-police mental health crisis response models. We'll start by talking about mobile crisis teams. And again, obviously the caveat is that this is kind of a broad category that we're lumping things into, but the idea here is that police are not the primary responders. So mobile crisis is housed and operated within the mental health system, but it's important to note that police involvement may not be uncommon, since police could be called at the request of the mobile crisis team. So this is usually teams of clinicians that are accessed through a crisis line or through emergency services, and they can request law enforcement assistance when safety issues are identified. In some ways, a mobile crisis team can be thought of as the same as kind of an EMS going out to a medical emergency, mobile crisis team going out to a psychiatric emergency. Mobile crisis teams have been studied to some extent, and the first descriptions really emerge in the literature around the 1970s. Because they've been around for longer, there is more evidence. In a 2002 article, they found that mobile crisis intervention increased the likelihood of using community mental health services in the 90 days post follow-up compared to people who used emergency-based hospital services. So they had two groups. One were seen in the community by the mobile crisis team, the other seen by going directly to the ED. And they found not only that were people receiving mobile crisis services more likely to then link to community services, but they were also less likely to be hospitalized in the month following their mobile crisis outreach. I think, one of the common themes that has been noted in the literature across several studies is that most mobile crisis teams generally do not have 24/7 availability or do not or cover very specific geographic areas. And so access for populations across the 24 hours a day, it has been a common finding and a challenge. I'll also note just quickly that there is some work around how mobile crisis teams can be effective in linking people to services or following up with them after they are discharged from a hospital-based incident. If we move on, I think the next slide is a quick slide on EMS and ambulance-based responses. Notably, in a study that looked at utilization of emergency departments, they discovered, this is an audit study, that people with mental illnesses or accessing services for mental health crises are much more likely to arrive at the emergency department through an ambulance. So ambulance usage has gone up over time, and people in mental health crises are taking up a larger share of those ambulance rides. There is a shift in some communities to use ambulances more than police to take people to the hospital. And there also is a movement, many of these have been discussed this week, around developing alternative facilities, crisis stabilization facilities, for example, where people can go instead of the emergency department. There are too many models to go into today, but one I think that's interesting and kind of appropriate for this conference, given its international tilt, is the model in Sweden called the PAM model, which is really a psychiatric emergency response, their version of it. I'll note that there's really little evidence across the board, but there is an article out there on the PAM model and its first year, showing that they had, over 1,500 cases, were able to respond to the vast majority of them, going out to 3 to 4 calls a day. We're able to respond in 20 minutes, so pretty fast response time, which is, obviously something that people are always looking at when it's a non-police option. And they found, interestingly, that in over a third of the cases, no further action was needed. So they were able to resolve on the scene. And then the other thing I think that's important to note is, even though that model is a non-police model, they did collaborate with police in 49% of the cases. So in almost half the cases, they had an active collaboration with police.
So now I'm going to talk a little bit about 911 dispatch non-law enforcement models. And the two examples I'll talk about are the CAHOOTS model, which has actually been around since the late 1980s, and a new program being piloted in Portland, Oregon called Portland Street Response. So CAHOOTS got started in Eugene, Oregon. The acronym stands for Crisis Assistance Helping Out on the Streets. It was a partnership that developed between a mental health clinic, the Whitebird Clinic, and the Eugene, Oregon Police Department. And what they developed was a model that included 2-person teams that would go out and respond to calls that were dispatched by police radio. But the teams include a crisis worker, which isn't necessarily a licensed clinician, but someone with good training and background in crisis response, and a medic, so either an emergency medical technician or nurse. And so the program was really integrated into their emergency call system, so that calls could come in and they could be dispatched directly to a CAHOOTS team, and that way taking the need for police or EMS response out of the equation. So when CAHOOTS teams go out, they do outreach, they respond to the scenes, but all of the services that they provide are voluntary. And the data that they have posted is that in 2019, they responded to 24,000 calls. And in only 311 of those calls did they end up requesting some police backup because of safety issues. So one of the things that they've really been able to demonstrate is that it is possible to have a non-law enforcement responding team handle a lot of the calls that are coming through. And I believe their data suggests that they responded to 20% of the calls that came through. So they're taking that need to respond, that burden off of law enforcement and EMS, and then providing a very specific crisis response to a very large chunk of calls. And one of the things that I think is really interesting about this model is that it really demonstrates that a non-law enforcement response can be safely implemented to handle a good chunk of calls that are in many communities right now. The only option is to have police and EMS respond to. More recently, the model called the Portland Street Response is developing in Portland, Oregon. And so what they did is, and they worked with, I believe they did work a little bit with Whitebird Clinic and got some input, but they decided to pilot a model that was based instead of at a community mental health clinic, but at the Portland Fire and Rescue. So it's based in fire and EMS. And their goal of their program is to reduce police response to calls for service involving people experiencing homelessness and behavioral health crisis in public spaces. So if you've ever been to Portland, Oregon, it's a really cool city, but they do have a pretty significant street homeless population. And so they've been working on ways to better respond and as much as possible to reduce police involvement in responding to crises that occur in public spaces. The team that they put together includes a firefighter, a licensed mental health crisis therapist. They also have 2 community health workers that can respond as well. And they're dispatched through their 911 system. So they just started launching the pilot in February of this year. And over the next 12 months, they're additionally kind of have more dedicated radio channel for Portland Street Response and really do some more work with how they dispatch the program. One of the things I like about some of the work that they've done is in developing and sort of finalizing what their model was going to be like to pilot is they spent a lot of time going out. They interviewed people that were experiencing homelessness in public spaces. They talked to a lot of different stakeholders, and they really brought in that community feedback to kind of come to a model that they were going to pilot. And of course, the plan is to do this initial pilot in one area and then to move forward and see how it goes and move it into other areas. And we're seeing a lot of different models like this start to emerge in communities across the United States as communities are really kind of trying to figure out how they can shift some of this response away from law enforcement. So I'm going to hand it over to Leah to talk about what we've learned about what mental health consumers want.
Great. So just quickly, this is such a critical question. What do mental health consumers want? And if you look at the literature, there is actually very little on this question, which is surprising and troublesome. And, I think Amy makes a good point that as communities are building models, I think we're doing a better job of engaging communities and asking them what the model should look like. But to date, we haven't done a good job of asking consumers and their family members what they think of the model once it's up and running and what their experiences are like. There is some qualitative research out there, as we will point you to our literature review, which includes those studies. Most of them are small, qualitative based, interview studies, but showing consumer satisfaction with different alternative models. But we really think it's critical to understand both the perspectives of consumers as well as their family members who are often with consumers during crisis and have their own experience of interacting with the different types of models. I'll mention very quickly that we are doing an ongoing qualitative research study that just kicked off. As Michael mentioned, we're studying this police mental health linkage system in Georgia. And as part of that, we're recruiting consumers to do interviews with us, qualitative interviews, as well as family members, to ask them really about both their experiences having access to different crisis response models, and then also what their preferences are. So we'll be looking at 50 patients and 25 of their family members to really get a better sense of what models have been dispatched to them in the past, and do they have preferences for what they would want in the future. So you can look forward to that.
Just as we start to conclude, I just wanted to emphasize a point that was made at the outset of this presentation, that we really need to think widely and broadly about the types of models that we want to develop in our communities, and they really do need to be tailored to our community context. You know, we know that models that are police-led could potentially exacerbate trauma or stigma, and we really need community voices to drive the needs and concerns, and to help us evaluate the models that are put into place there. So I think we're at a time and a place now. We had an interesting workshop the other day where we were working through different scenarios and sort of imagining if we could design models from scratch, what could this look like? And in what situations do we actually need to have a law enforcement presence there? And that was a really rich dialogue involving members of the law enforcement community. And we look forward to engaging that into the future, that perspective that, you know, we could actually imagine non-police options in this space. Also, just to end on one of the first points that was raised as well around institutional racism, you know, we know from some of the spatial research that locations of mental health related calls do cluster in areas of disadvantage. We know that levels of trust in police vary spatially, vary by area. We know that inequities cut across the sectors of health and law enforcement. So again, we really must think when we're developing and testing models that they have to be tailored to community needs. And there's just so much that we don't know yet in terms of the ways in which bias could actually be baked into the institutional arrangements we have for, you know, providing better responses. So we really have to think carefully, and again, have community voices sort of drive the innovation process and make sure that we don't unintentionally exacerbate racial disparities in the models that we develop.
So now we have a little bit of time for questions, and I know Jen indicated that we actually can go a little bit over because there's not something else on this channel. So I'm gonna move into here. I know we have some questions in the chat. Let's see. So I see a couple questions just on if there's any evidence of mental health responder safety when non-police teams arrive alone, as well as if there's any third-party independent research that we found on Cahoots. And I can start with just in terms of mental health responder safety when non-police teams arrive alone. I haven't seen anything specific in the literature. It certainly is an issue to look at and will be important as we develop these models that we look at our triaging decisions, as well as making sure that we prepare the responder teams to also make decisions as they respond to a scene, you know, so they can assess safety and make decisions also about whether they do need to request additional support from law enforcement. But at the current time, I don't know if any of my colleagues have seen any research specific to that issue. Okay. And I see there's also a question about third-party research on Cahoots. And again, I have not seen anything specific to third-party research. What I have found is what, you know, their own sort of descriptive evaluation data, but certainly there is a need to get some research going on Cahoots, as well as some of the other models that are emerging, so we can really look at and learn from these programs, and again, have some good solid data to make decisions on. So
I'll just jump in because I noticed a question on the website as well, which is really interesting. And the question is, while there's greater interest in non-police response to mental health emergency calls, sometimes these are wrongly classified as public safety emergencies. How can this risk of misclassification be mitigated and ensure a health-based response in these instances as well? And I would just say, I think that's a really great question. I think a lot of what I've been thinking about through the different sessions this week gets back to the issue of dispatch and how calls come in and how they're triaged. And as part of our panel earlier this week, we had a really rich discussion about, who makes the call about public safety and kind of what's that tipping point. And so I don't have a great answer. I just think it's really important as we're building these systems that we're also thinking about how they're going to be dispatched, when and how, and continue to kind of push the bar on minimizing the extent to which police need to go out.
Yeah, and to add to that, I think, some of it is the triage protocols and training at the 911 level, but also making sure that if police are dispatched and it turns out that they don't need to be there, having some mechanisms so they can very quickly get a more appropriate response. And then there could be some value as well in educating the community, so that if people are calling, helping them better describe and ask for the most appropriate response as well. So there's a number of things that could be done to sort of address that issue.
There was an interesting question that just came into the chat from Victor. Is there any consensus as to which model is most appropriate in a particular environment or scenario? They all have invaluable benefits, but I'm wondering how decisions are made regarding which ones. Whoops, sorry, another chat came in. Regarding which ones to fund and implement in different areas. That's a great question. I think it was part of the reasons why we had a session the other day where we were sort of it was a scenario-based workshop, thinking about, what would be the best sort of model for given scenarios. And we varied that in terms of situation, in terms of potential safety risks, presence of a gun, presence of other weapons, and in other situations. So I don't know if there's an answer to that question, because we really haven't done scenario-based research. It's been more just researching models, but not sort of tailoring models to different scenarios or trying different models with different scenarios and then evaluating them.
I see I have a question that came in through the Q&A, is how do we get law enforcement to partner with researchers as these programs are developing? Agencies are developing all these different models, and it will become harder to study rigorously, such as with an RCT. Really, really good question. I know, one of the things that we struggle with too as researchers is, we see things emerging in communities that we really think, wow, we could do so much if we can get some data, going. And sometimes we even get agreement to partner with, the law enforcement agencies. The hard part is then to get the funding to do it can take a very long time. So sometimes that doesn't line up very well to actually get in there and be able to move forward. So it's a struggle. But I do think, I think there's more law enforcement agencies that are open to having researchers kind of assist from the beginning. But we really do have to line up some of the funding mechanisms to allow us to get in there quickly too, because sometimes doing a really robust evaluation, I think, takes resources. I don't know if my colleagues have anything to add to that.
No, just to say, Claire, that was a fantastic question.
Yes.
Thank you for that.
And maybe some of our funders too will hear, like, we need to figure out some mechanisms so we can get in there early as things are emerging, because police agencies can't wait for researchers to bring in the resources to do whatever it is they need to do. They're implementing models based on a need. They can't necessarily wait 2 years for your funding to come in.
So one of our attendees is I think we're researching the psychiatric ambulance model in Stockholm, Amsterdam, and London, and was just wondering if there was anyone else working in that space. So I hope that you can make connections with one another through HUVA, because that's certainly a fascinating model.
So I see. So here's a question about, and I'll read it. At the root of your studies is increasing in an intent to refer to treatment rather than arrest and reducing stigma. You've done such interesting work in that regard. Thank you. Do you think your findings and techniques are generalizable to substance use as well, or can help form the basis of similar interventions? I think that's a really good point. I do think they are, and I'll ask some of my colleagues to chime in on this, but there's been so much attention on mental health, but oftentimes the stuff we're talking about also includes people experiencing substance use related crises. So I do think there's a lot that is generalizable. Leah?
Yeah, I was going to say a similar, thanks for the question, Brandon. I think that in some ways we've created some artificial differences in like talking about mental health crisis response models versus substance use models like LEAD. I think there are many similarities between them, and often we're talking about the same people just at different moments of crisis. So I think some of the findings definitely are generalizable, and I think actually, you know, it's useful for us to maybe change the conversation a little bit so that we're talking about people who are in crisis and they may be experiencing different issues, but could be helped by similar services.
Yeah. So Jen, do we need to wrap up?
I'm being told by the IT gods that we need to start winding up.
Okay.
So certainly encourage folks to keep up the dialogue through the Whova platform, and of course reach out to us individually as well, the four of us.
Yes, and we'll try to get the documents that we discussed posted in the Whova app, so people have a direct link to some of the things on the Vera Institute of Justice website. So, great, thank you, everybody.
Thank you,
Thank you,
everyone.
everybody.
All right, bye.
Bye.
Bye.